Next presentation is going to be by Dr. Ogara, who was here last year as well and gave an excellent presentation. So this time, Dr. Ogara is going to talk about controversies in guideline development. Please, Pat.
Thank you very much, Dr. Rosenman, Dr. Segev, Dr. Balatin, and Dr. Ketchel. I very much appreciate the opportunity to participate in this Israel Heart Society American College of Cardiology Joint Symposium. This is a wonderful opportunity for someone like myself to visit your country a second time. And believe me, it is as impactful this time as it was last year. Thank you very much for sharing your culture. Thank you very much for sharing the common threads of our different religions. I notice the Armenians have a lot of good real estate in Jerusalem. Sort of working on that, but we'll get there. And I have no disclosures to make relevant to this talk. I will not speak about my own personal diet, and you would be embarrassed to know what it is I eat on a regular basis for lunch. But let's move on and make sure I know how to advance the slides. So what I thought I would do in the 20 minutes that I have is simply share with you some concerns I have about how our guidelines are developed and how they appear to be out of date so quickly. Doesn't it frustrate you as somebody who has to take care of patients, and yet you stay up with the literature and you constantly wonder whether or not the people who develop guidelines know what they're doing, have any experience taking care of patients, or are they all asleep at the switch? No, we're not lawyers, but thank you very much for that comment. In case you didn't hear it, I was accused of being an attorney. I think in the interest of time, I'm going to say just a few words about how far behind we are with respect to our approach to patients with ST elevation MI, and I'm going to spend the bulk of my time talking about some changes in the approach to patients with valvular heart disease that I also think have pushed the envelope and require us to re-look at what we're doing and as quickly as we can. This is the algorithm by which we in the United States have recommended that patients with ST elevation myocardial infarction be managed in the early hours after onset of symptoms. And for those of you who are nice enough to read our guidelines and compare them with the European Society of Cardiology guidelines, you will notice that they are essentially identical. And you will also quickly understand from this particular slide that the major difference over the course of the past 5 to 8 years in terms of how it is we approach patients with STEMI has to do with what's in the yellow boxes. And the yellow boxes simply summarize that even following successful reperfusion with fibrinolytic therapy, we are now moving relatively quickly to angiography, definition of anatomy, and performance of PCI, even following successful fibrinolysis. That's really the only difference, I think, that has occurred in the past 10 years. The rest of it is really a rush to create an open artery as quickly as possible. And it's wonderful to look at this and then to ask the following questions. Do you think that door-to-balloon time is an appropriate performance metric in the 21st century? Now, I ask this question, of course, because we've all seen recently, at least in the experience in the United States through the NCDR registry, that there's a disconnect between door-to-balloon times and then the hospital mortality rates on a population-wide basis. Hospital mortality rates for STEMI in the United States have been stuck at about 10 to 12% over the course of the past decade. Yet door-to-balloon times have fallen by about 25% over the past 5 years. What accounts for this difference? And I'll defer to my colleague, my friend and my mentor, Dr. Antman, who also emanates from Massachusetts in the United States, about a more in-depth analysis of what appears to be this discrepancy. But I think that most would agree that it perhaps relates to the type of patients we're now taking care of with acute intervention. We're taking care of people who are much sicker, perhaps, than they were before, people who would not have been offered reperfusion compared with what is the situation now in the 21st century. And maybe what we have done is we've misunderstood the demographic of the population of patients we're caring for with STEMI. But we should not lose track of all of the benefit that comes from shorter door-to-balloon times. Who wants to go back to a past in which we were fiddling around with hours going by before reestablishing myocardial perfusion as quickly as possible? This is a good metric on a local level, and I think there's a discrepancy when you apply it to the individual patient compared when you apply it to a population of patients with STEMI. I'll draw your attention to a recent article that Dr. Krumholtz's group published in Lancet that is a follow-up on their observations that they published in the New England Journal of Medicine a couple of years ago. Here's an easy one. When do you think that thrombus aspiration should be performed? How many of you are still doing it in your interventional practices? Okay, so I think the burden is on you to tell us as non-interventionalists exactly what are the characteristics of the thrombus or the flow that substantiate the use of aspiration thrombectomy, because we still have a lot of difficulty understanding this from the perspective of the non-interventionalist. I think we have to be very respectful of interventionalists, just like we should be respectful of cardiac surgeons. I actually believe that judgment and experience trumps most of what it is that we can get out of a guideline. So I'm very respectful of your individual judgment, yet the studies that now have been published, including 17,000 patients across 2 studies, show absolutely no difference. And we have difficulty understanding exactly when it is that you decide that this is going to be in the patient's best interest. So there's a little bit of a challenge, I think, for all of us to grapple with. When do you think that non-culprit artery PCI should be performed in patients with STEMI and multivessel disease? How many of you do it at the same time as infarct artery PCI? How many? How many of you take no prisoners, even in patients without shock? So you do the LAD and somebody with an anterior STEMI, they have an 80% right. Do you do them both at the same time? Sometimes. Okay, so you'll have to tell us when it is those sometimes occur. Now, how many of you do it in a staged fashion before the patient leaves the hospital? A few. Okay, and how many of you do it 3 months later? Okay, so some do it after hospital discharge. How many of you are relying on exercise stress testing in the 21st century to dictate when it is you do non-culprit artery PCI? 0. How many people are doing FFR routinely? Okay, to decide when it is you're going to do non-culprit PCI? Interesting, isn't it? Because most of the data on FFR derive from patients with stable ischemic heart disease. So I think we have a little to learn there as well. See how far behind we are? Okay. And what do you think is the appropriate duration of dual antiplatelet therapy in patients after STEMI? How many think 12 months? How many think more than 12 months? How many didn't vote? How many would like to say, I don't know? Okay. So we're all in agreement there. But these are some of the issues, I think, that we need to grapple very carefully, very sequentially, very thoughtfully, and I think in collaboration with our European partners. Doesn't it also drive you crazy that the Europeans would publish a guideline and then a year later the Americans publish a guideline, and sometimes they're not the same? There are a lot of obstacles in the way of our doing business together, but let's look towards an improved future of collaborative guideline development. So that's my little spiel on STEMI, and I sweat every day, having been the chair of the writing committee, and I didn't get any answers from the audience here about how it is I'm supposed to clarify the answers to those questions. So perhaps I'll come back next year. So let's move to valvular heart disease, which is a close second. I see Dr. Puskas here in the audience, and I'm going to share with you some of the interventions that our cardiothoracic surgery network in the United States and Canada have put together over the course of the past couple of years. And this, of course, is to keep our 2 cardiac surgeons who are co-moderating this session awake. Otherwise, they probably wonder what they're doing here and they're not in the operating room, I suspect, right? Well, you're sort of waiting for us to get to the answer, huh? Right. Okay. So here's the first question for the audience. Do you think you can perform a randomized trial regarding intervention for patients with severe asymptomatic valvular heart disease? Wouldn't that be fantastic if we could actually do a study in the 21st century of patients with severe asymptomatic aortic stenosis and normal left ventricular function? And I truly mean asymptomatic. You've generated the history, and in some cases you've even done an exercise test to corroborate that. And you know how anxious and apprehensive the world is about managing patients with asymptomatic severe aortic stenosis. This is a very pertinent question in the United States, and if we, I think, mess this one up, we're going to have quite a big price to pay. I think the same actually is true for mitral valve disease, but maybe that's even more controversial. Here are some of the elements, I think, that challenge this particular kind of questioning. Namely, does equipoise exist in our surgical and cardiology communities with respect to asymptomatic valvular heart disease? I think not. I think some believe very strongly that the severity of the lesion dictates the indication for operation, even in the absence of symptoms. So we'd have to revisit the question of how comfortable each of you would be in randomizing your patients to one strategy versus the other. Secondly, of course, how much money would a trial of this type cost, and over what period of time could it be done? Lots of years to prove a mortality benefit, I should say a survival benefit, in patients who undergo earlier operation. Lots of years, right? Avoidance of heart failure and death. And then, of course, how it is that you inform your patients so that they can make a reasoned decision. Oh, by the way, if you go down this pathway, you have to have surgery next week. How do you think your patients are going to feel? This is a little different than saying you take this sugar pill or you take this active intervention for your blood pressure. So randomization in surgical trials is a horse of a different color. And we have to be very respectful and grateful for our surgeons who've actually blazed this particular pathway. Do you think transcatheter therapies are going to change this paradigm? Do you think that patients and their physicians will be more willing to sponsor them for an active intervention if we get to the point where transcatheter therapies are so good and so safe that they would begin to think about undergoing intervention at an earlier stage in their natural history? Right now, they're not, right? Right now, open aortic valve replacement surgery is kind of hard to beat in a low-risk patient. But let's see. Anyway, here's a question, and this, I think, is the paradigm of decision-making that each of you needs to undergo every time you see a patient with asymptomatic valvular heart disease. But let's not forget, this is a little different than having a wisdom tooth taken out or your appendix taken out, right? People die and have stroke following cardiac surgical interventions despite the best of techniques and the best of intentions. And I think for all of us who've had experience, it only takes one patient, relatively young patient, who had an unpredictable stroke following an operation because of an air embolus or perhaps because of particulate matter embolus to the brain that would actually change the degree to which you feel courageous enough the second time around to proceed down the pathway. So here are some studies that I've been part of, as well as Dr. Puskis, with respect to answering some of these questions. Let's get first, before I get to the NHLBI studies, this question about asymptomatic patients with degenerative MR. This kind of question appears on billboards in the United States. Come here for mitral valve repair. Right? We do more, you will do better, you won't have atrial fibrillation, heart failure, or die early if you have your severe MR fixed. And I'm talking about primary degenerative MR. I think the decision needs to be individualized. I think across the world, a lot of concern was raised by this observational data set that Maurice Serrano and colleagues put together from across the United States and Europe, looking at the reduced survival among patients with severe MR due to flail leaflet. This is an observational data set. About 10% of these patients were actually symptomatic at time of inclusion in this observational registry. I think there's some flaws here, especially when you compare it against the Rosenheck experience from Vienna and a dedicated heart valve center of excellence following patients carefully with echo and clinical evaluations every 6 to 12 months, showing no difference in long-term survival in patients who were followed expectantly, compared to an age and gender matched cohort of the general population living in Vienna under the same time frame. So I think there's a little bit of discrepancy, and of course, all it takes is a couple of these. This is a post-operative echocardiogram in somebody who underwent surgical intervention for asymptomatic left atrial enlargement of a progressive nature in the context of myxomatous disease. This happens, doesn't it? I mean, if this doesn't happen, you're probably not doing enough mitral valve surgery, right? Things happen. This is a difficult situation in this particular patient because of bileaflet involvement compared to isolated posterior leaflet involvement. And in the United States, I'll leave you this observation from Steve Bowling, who's a very prominent mitral valve surgeon. The average number of mitral valve procedures, and that's repair, replacement, or commissurotomy, among surgeons in the United States on an annual basis is 5. So that's 1 every 2 months or less. So that raises the question about being careful for us cardiologists with respect to the surgeon and the center to which you would refer your asymptomatic patients. So let's move rapidly among 3 questions about ischemic mitral regurgitation. And the audience understands that ischemic or functional MR is completely different from myxomatous or degenerative MR. This is a disease of the ventricle. This is a disease in which the valve is an innocent bystander. And yet this is a disease that has a horrible long-term prognosis as a function of the severity of the mitral regurgitation. Do you think that mitral valve repair should be performed routinely in patients who have moderate ischemic mitral regurgitation? So 5, 6 years ago, of course, this was routine. Moderate mitral regurgitation on a preoperative transthoracic echocardiogram in a patient referred for CABG, equated with CABG plus mitral valve repair. What are the data? No one size fits all. This is the kind of ventricle we're talking about. This is probably moderate ischemic mitral regurgitation by integrative criteria. Big ventricle, regional wall motion abnormalities, tethered mitral valve apparatus, and in this particular case, a central and slightly posteriorly directed jet of moderate MR into a dilated left atrium. Well, in our cardiothoracic surgery network, we actually did perform a randomized study of 301 patients with this particular demographic. The results were published just last year in December, and Peter Smith was our first author. Look at this. Major adverse cardiac and cerebrovascular events over 1 year, no different between patients who were randomized to CABG alone versus patients who were randomized to CABG plus mitral valve repair. No difference. And our primary endpoint was left ventricular end systolic volume index, which is a marker of reverse remodeling. No difference in the primary endpoint at 12 months. What did we observe? Well, not surprisingly, we observed the following. The patients who underwent repair had less moderate or severe mitral regurgitation at 1 year compared to patients who underwent CABG alone. As you can see here, the incidence of moderate to severe mitral regurgitation at 1 year in patients undergoing CABG was 30% compared to about 10% in patients who actually underwent repair. Why are these data important? Well, nearly 70% of patients randomized to CABG alone had only trace or mild MR at 1 year. Interesting, right? And a full 10% of patients who underwent repair still had moderate or severe ischemic MR at 1 year. Again, speaking to some of the problems associated with repairing functional mitral regurgitation under these circumstances. That's a bit startling. Do you think that patients with severe, now I'm talking about greater degrees of ischemic MR, should receive repair or replacement? Cardiologists have generally been brainwashed that repair beats replacement under most circumstances because it's less of an impediment to recovery of ventricular function, right? So what did we learn? Approach may need to be altered. And here again, we looked at patients randomized to replacement with cord sparing versus those who were given repair for severe ischemic mitral regurgitation. And as you can see here, 1 year death rates in both groups approached 15%. 15% of patients, even following surgery, died at 1 year. And these are at high volume, high quality academic surgical centers. This is a highly mortal disease, ischemic mitral regurgitation. And again, we found no difference in the primary outcome related to reverse remodeling, and we saw no difference with respect to a composite of major adverse cardiac and cerebrovascular events. What did we find? We did find that in patients who underwent repair, the incidence of moderate or severe recurrent mitral regurgitation at 1 year is about 33%. So a third of patients undergoing what for many has been the standard operation have this kind of an outcome. And most of that early mitral regurgitation occurs within the first 90 days. And lastly, what about the performance of atrial fibrillation ablation at the time of mitral valve surgery in patients who have persistent or chronic persistent atrial fibrillation? This seems to be kind of a routine, doesn't it? Anybody with atrial fibrillation now undergoes surgical pulmonary vein isolation and/or a maze procedure. And what did we find? Well, we randomized 260 patients, and we ablated half of them, and we just did mitral valve surgery in the other half. And as you can see here, the data slides don't show, but they were published. There's no difference. There's no difference, unfortunately, here in long-term outcomes with respect to survival. But the performance of ablation is associated with a reduction in the incidence of atrial fibrillation at 1 year, but at a cost of an increase in the need for permanent pacemakers by about 20%. So I think the purpose of my showing you these particular slides is to demonstrate that our surgical colleagues have moved into the era of randomized controlled trials and have brought a lot more clarity to common questions that affect both of us as cardiologists and cardiac surgeons. And my last comment with respect to valvular heart disease has to do with what I call indication creep for TAVR. And are we becoming so accepting of this particular approach, which is so dramatic and so seductive and so wonderful? Patients spend about, 1.5 days in the hospital after an intervention, even though they're in their mid-80s. We are applying it to lower and lower risk patients, I think, really in the absence of information. And you can see here surgical results are still quite good. And lastly, that in our TVT registry, which is a combined effort between the Society for Thoracic Surgery and the ACC, we looked at what's happening in the United States following the commercialization of TAVR. What's happening in the United States? Let me just draw your attention to this far right box with whiskers, as you can see here in those standard error bars. As you can see, that the median predicted STS risk score for the patient population in the United States undergoing TAVR in the first year of its commercial availability is about 6%. That would equate to intermediate risk. This was released for patients at prohibitive or high surgical risk. Now, there may be a lot of patients in here who have unmeasured variables, but the implication is within a year of its release, it has been applied to lower risk patients at this particular point in time in a data-free zone. And if we are going to apply this to even lower risk patients, I think we need to sort of take stock and be careful about how fast we're going in this direction. So in conclusion, I think there's no question we'd agree that the guideline process is cumbersome. New trials frequently appear between completion of peer review and publication. And don't we need a more dynamic process that is done collaboratively across the continents so as to keep the eye on the prize and improve patient care at the point of care? Thank you very much.
Thank you very much.
You on a brilliant talk. But as the dinosaur of cardiology from South Africa and from this little country, I'd like to say that when Timmy 1 was instituted, we did a little study in Jerusalem doing home thrombolysis. And we showed very clearly that if you did the patient within 1 hour, you salvaged myocardium and the patient did well. We had no controls. The papers of the New England Journal of Medicine, it's very little quoted. Why? Because we didn't do what we should have done, have the control subjects, because we believed in what we were doing. So I think we need to go back in acute myocardial infarction. The problem is time. And there are hundreds of papers now, hundreds of studies which are appearing, but no one realizes you've got to be there in the first hour. In Jerusalem, the ambulance takes 5 minutes to arrive at the patient's home. It takes 30 minutes for the patient to call the ambulance. That's 35 minutes. It takes another 30 minutes for the young doctor to make the diagnosis, and then we'll be using intravenous Intravenous, not TPA, because it was $1,200. We were using streptokinase. Okay?
Yeah.
The results were superb. The patients lived for a long time. They had good ventricular function, and we had wonderful results. I've also worked, I was known as the man who put iron, metal plates. That's what the editor of the American Heart Journal called me, putting little pieces of metal in children. And we showed this as in 1965 and 1966. In fact, if you put little pieces of metal in little children who had severe mitral incompetence, they had wonderful results. So I think we're going forward, but we're forgetting the past.
Thank you very much.
Thank you very much.